रहीम रमज़ान रेडियो वुल्वरहैम्पटन की जानिब से आपका मेज़बान डॉक्टर रिजवान गिलानी हेल्थ क्लिनिक के साथ पेश हाज़िर खिदमत है। तमाम देखने वाले और सुनने वाले सामईन को मेरी तरफ से अस्सलामु अलैकुम वरहमतुल्लाहि वबरकातुहू। अल्लाह ताला कुरान पाक में फरमाते हैं, इन्नल्लाहा व मलाइकतहु युसल्लूना अलन नबी या अय्युहल्लज़ीना आमनू सल्लु अलैहि वसल्लिमु तस्लीमा। अल्लाहुम्मा सल्लि अला मुहम्मदिन व अला आलि मुहम्मदिन कमा सल्लैता अला इब्राहीम व अला आलि इब्राहीम इन्नका हमीदुम मजीद। अल्लाहुम्मा बारिक अला मुहम्मदिन व अला आलि मुहम्मदिन कमा बारकता अला इब्राहीम व अला आलि इब्राहीम इन्नका हमीदुम मजीद। So, dear listeners and viewers, a very warm welcome to our show, Health Clinic with Dr. Gillani. Today's Health Clinic, again, after the previous very successful program with our dermatologist, we were asked to put back another program to discuss a couple of very important issues around skin conditions. And today, again, our special guest, Dr. Shahid Rafiq, has very graciously joined us for this program, which will again be on skin conditions. He is a GP with special interest in dermatology, and he does a specialist clinic in dermatology at local hospital for well over 10 years and have got an extensive experience of dealing with skin problems. And it is an honor for us to have him on our show, and we welcome our guest. Assalamu alaikum, Dr. Sir.
Assalamualaikum. Thank you for inviting me to Rizwan again.
Thank you very much. Its pleasure is all ours, and it is very kind of you to give us that much time again. So today's topic we have put together because it was those topics which were asked by our audience to be discussed on this show. Two topics today which we will discuss. One would be hair loss, and other one is going to be any pigmented skin lesions. So I think we will start without any delay with our first very important subject, which is going to be hair loss. Extremely common question which you get asked whether you work in primary care or you work in specialist care, or even if you will hear various conversation among group of people, especially females, you will always come across this question of hair loss. So we will perhaps start from this topic. So Dr. Fee, can you please tell us about hair loss and how should we think about hair loss whenever we think about it?
I categorize hair loss in two categories. One is scarring alopecia and also non-scarring alopecia. Scarring alopecia does need urgent attention from the GPs and under referred hospital, and that's why very important. So other one is non-scarring, where we can discuss female pattern hair loss, which is very common, and also um, male pattern hair loss, which I think we can discuss female pattern hair loss, and also some hair loss which is related to genetic alopecia areata, which is very common in our community because it has autosomal autoimmune disorder related to diabetes, thyroid problems. And third one, trichogenic film, which is very common, especially the ladies, especially when they have a baby born after pregnancy and after illness. So we just go back to our scarring alopecia. We come across some patients who has hair loss, but they can't see the rash, itchiness, and sometimes they present with inflammation or any pus follicles in the hair. In that case, if they have a rash, itchiness, okay, that they need to contact the GPs, because if you pick at this stage, you can prevent the because scarring is permanent hair loss. Once you lost hair, you can't hair back. So in that case, these patients, instead of trying over-the-counter shampoos, other things, they need to contact the GPs, so there can be urgent investigation. They can be referred back to a hospital setting or community setting for biopsy and further treatment options available.
Okay, so Uh, just for the clarification of myself and for my listeners, uh, you are saying that the hair loss, which we called alopecia, if it is appeared to be leaving any scars behind, when you lose hair from a surface and you can see there are a bit of scarring left, you call it scarring alopecia,
Yeah.
and that is one of the sort of serious conditions which needs to be dealt with. Am I right?
Yeah, because these can be, if you dealt early stage, you can do investigations and you can these can treatable, so it prevent the further hair loss. Because certain conditions like a planners or lupus, they can cause hair loss, and the other condition which can cause fundal fibrosing alopecia, which is another very common in females above 40. They have a hair loss on the front of the scalp only. They don't have whole hair loss other part of the scalp, just in front of the scalp. If you pick up early stage, and they can be treatable, and there's some medications available for them. Okay, and that's why I think it's very important. If you think the hair loss, we can see scar, but there's no hair loss coming. There's no hair coming back at the site. They need to contact the GPs instead of over the counter, and GPs also need to refer to the hospital setting for further assessment and treatment options.
Great. So the message is that if you are seeing any scarring and if it is scarring alopecia, report it early to the general practitioners who are very likely to refer you to the specialist dermatology services. And the good news is that quite a few of them can be treated, although not all of them, because they can be due to some underlying causes which might need treatment first. But quite a few of those categories, if treated early, you can prevent further hair loss.
Yeah.
Okay, great, excellent. So that's scarring alopecia, which is a bit of worrying news, but at the same time, I think we need to be aware of that as well. So thank you for that. So there is other variety of hair loss when you get the hair loss, but there are no scarring, which you call non-scarring alopecia.
Yeah, so I think we discussed androgenic alopecia, which is a related to hormones like and testosterone, which can cause hair loss. So we discussed in men, it's more of it can start early, but it can be hereditary also. So if you have two parents have it, then you have more chances. If you have one parent have it, so you have more chances. So
So it is hereditary, which means that it runs in the
it's
families.
run the family.
And you said, I mean, we very commonly see that the father would have that hair loss, and then you will see it in the son. But you also mentioned that if both parents can have hereditary alopecia.
It can happen sometimes if you have a female who has a hair loss, which is female pattern hair loss normally age of and in the female is 60, but they can be within 30s, 40s. If you then that can more chance of hair loss in the kids also, especially if female has hair loss starting early age, the mother might have a hair loss at early age.
Right. Okay. So obviously, maybe they have got too many hairs. That is why we don't see it as pronounced as we see is it men. But you say that even in the younger women, they can have the similar kind of
Yes,
loss of hair.
yes, it can be.
Okay. So what can we do about it? I mean, the one thing we normally tell our patients is that you can't change your parents, unfortunately. So, is there anything which can be done?
The, for this kind of hair loss, it's not, you can't cure it. Okay, but I think if you find few things which can be contributing to hair loss, especially if you have there's evidence coming up if you have low iron levels, low vitamin D levels, zinc levels, and they can promote the hair growth. But otherwise, I think it's more hormonal. Okay, and also sometimes you can relate to the especially female, they have polycystic ovarian disease, so it can be they've been tested for it, they can hair loss on this one also. All the polycystic can cause increased hair growth, but on the other hand it can cause also hair loss.
Okay, so other than you go through the family history and you perhaps try to look for those deficiencies, what kind of symptoms should prompt a person to seek help?
There's no women normally have a generalized hair thinning also. Normally they start on the crown, okay, on the top, and on the sides. Men's come from the fronts, okay, but the women's start from top and also generalized hair thinning especially women's. So if it's women's losing hair on generalized thinning, they have to think about female pattern hair loss, and they contact the GP. Sometimes it can lead to thyroid problems also. So anti-thyroid, overactive, they can be, but there's no direct link with it. As compared to alopecia areata, there's a direct link with the alopecia areata, but with this one.
Okay, we will definitely come to that. My own observation is that not many men will come, without sounding being sexist, not many men will come and seek help in regard to the hereditary alopecia. I think they just take it on chin and say, okay, my dad looked like that, I'm going to look like that as well. But the biggest challenge, especially the primary care colleagues usually have, is the women come and ask about the hair loss, and they are very stressed about it, and they want something needs doing about it. So what can sort of we do or say to these people?
I think we just do the blood test underlying, okay, first to make sure no deficiency of. Then afterwards, treatment options are difficult. You can start from limited on NHS. So you can have a minoxidil, which is for women. So you can 2% solution can be used, okay, and other than that, a lot limited options available for especially women. Okay, now the hair transplants come later on, but I think they were limited. There are a lot of people use shampoos. Which is a shampoo with some cold caffeine shampoo, other things, but there's no evidence that it does anything work.
You will see all the time the claims on the telly are that it will give you really strong hair and it will help you. All that, you don't think there is any evidence behind?
There's no much evidence unless you have some inflammation. Okay, sometimes you have inflammation, underlying inflammation going on, and the hair loss. Then you can think of they might help in bring the inflammation down. Some shampoos and can cause some sort of stop the hair loss. Otherwise, it's difficult.
Okay, so hereditary hair loss, I think it's overall bad news. You can't do much about it. It runs in the family. Not many treatment are available. Very famous nowadays, you will see almost everywhere hair transplant options. And I see lots of people are going abroad to get hair transplants. So is that the only condition where it is helpful, or people seek help in this, or what is your experience about it?
I think the hair transplant, again, I think depending where you're getting it. Okay, there are some treatments available in the private sector, PRP, and which has been which is a plasma. They take the bloods from there, take PRP treatments, which is also some evidence coming. It does help, and along with hair transplant, ideally the world should be done in this country, because it have complications happens. That's a problem. We see some patients who have hair transplant done overseas, and afterwards they have infections, other things, and which can be nowadays I think it's difficult to dealt on NHS level, because they said you had to go back to the surgeon who did it. So either if you want to do on NHS, NHS don't fund any hair transplant, you have to go privately. And a lot of clinics available, but I think you have to try who's the best one and look at reviews.
Okay, so obviously the hair transplant could well be a very costly option for people as well. And you mentioned that there could be some topical treatment. Is that suitable for everybody, or there are contraindications?
They are, I think, because some people have some inflammation already there, so you can't use this lotion because they can cause more inflammation. And a lot of preparations are available in a solution form. Foam is better than a solution, because foam you can put on the hand and rub it on. It's better as compared to a solution. Solutions are over. Okay, and it takes about 6 months before you see any results with the minoxidil if you want to use it. It's called Regain. So there's different brands available. So underlying chemicals, minoxidil. So you about 3 to 6 months you feel, and sometimes as long as you use it, it's okay. When you stop it, you may shed the hair again if you already have a genetic problems. Because
Okay. So it doesn't sound too promising. Are there any other solutions for this kind of problem?
I'm afraid there's not a lot available for this kind of hair loss.
So, I mean, I think the bigger issue people have is that when they go out and socialize, and then they need to, perhaps there is a common feeling in many people that if they have hair, then there will be hairstyles, etc. So, what can they do temporarily?
They can have wigs available, okay, and if you NHS provides some wigs. Some patients have just lost a lot of hair, okay, and then they can be wigs available. You can give them. Other than that, it's difficult to. Or camouflage can be some of the camouflage spray available, but you can buy over the counter. But otherwise, I'm afraid it's limited options, treatment options. This kind of hair loss.
Okay, fair enough. That's fine. So I think that's pretty much what we needed to know about hereditary alopecia. So tell us a bit more about alopecia areata. That is the more common one, which perhaps we can do something
I
about.
think yes, alopecia areata again. It's a hair loss which can be sometimes you see some patients all of a sudden they have hair loss. Sometimes they have some irritation before they can see coming on the scalp. So it can be on the bed areas. It can be other part of the body also. So all of a sudden the patient notice they lost the hair and overnight. Okay, and only with the alopecia areata, it doesn't affect your white hair. It does affect only pigmented hair only. If you see, okay.
Oh, that's good news then. So if you have already got gray hair, no
Then,
need to worry about.
Yeah, I think sometimes you find difficult. What happened? They have only gray hair left. Okay, there's no the hair left over. So that's would normally happen. And also it's non-scarring. Okay, so some patients use eyebrow, eyelashes. Okay, and sometimes you can have a regrowth chances are better if your hair loss is less in the beginning. If you have lost the hair a lot in the beginning, I can chance of regrowth is very low.
So is that only happen on the scalp, or it can happen anywhere?
It can happen the beard. Mostly we see in the beard area, on the scalp area. It can have other part of the body, but it can be more. There's a more common. Some eyebrows, eyelashes can happen, and
And how does it look like? How what should the people look for to say it is very likely to be alopecia areata?
you see when you feel it, you can see the smooth surface, and sometimes you can see hair coming out of it. Okay, and you can feel a single hair coming out of it. We call it medical term exclamation mark. If you see something a hair standing out of it, all of a sudden in one of the bald patch, it's been alopecia areata. So in that case, I think they can seek advice from GPs about it.
So how big these patches normally are, or they can be different?
It can be different, some small size, large size. So they are maybe start one patch, and you think okay, but all of a sudden you find other patch coming up, and that's bad news in that case because it means it may be turned to the severe kind of alopecia. So
what causes that?
it's caused due to something immune system that causes inflammation in hair follicles, and what happened? The hair follicles there, but it's gone to sleep.
Right.
Okay, so and some patients, lot of patients who are high risk are just patients who have thyroid problems. Okay, and underactive or active thyroid. So that's why I think it's very important. You have to see GP to have a blood test thyroid. Sometimes it can relate to other autoimmune diseases, especially Asians. They have a family with diabetes, families with thyroid problems, pernicious anemia, rheumatoid arthritis. Sometimes it's a clue for the patient, also for the GPs. If you think okay, they have families with thyroid, or they have a history of thyroid, they have family with diabetes, or they present with hair loss, and especially ethnic community, it means most of it's alopecia areata. That's why I think it's very important when you're able to distinguish between the hair loss you can think of.
Okay, so it means that there is still the family element, hereditary element in it.
20% patients have a hereditary element. Okay, and normally they can be. Sometimes you have diffuse hair loss. You can have hair loss totalis. You can humerus. You lost whole hair in the scalp area.
All around the body, or just the scalp?
On the scalp, or it can be all over the body. Some patients.
So eyebrows, beard.
Yeah, everything.
Oh, that could be really daunting.
And that's difficult to treat also. Okay, and you can't cure it.
Right. Okay. So this alopecia areata how do we diagnose it?
I said to you, I think if you have someone present to you with a hair loss, and you have a sudden hair loss over a couple of weeks, and you found one bad patch, and you can feel it, And also, and if you got a family history of thyroid problem, diabetes, or have someone run the family, 20% run the family, one of parent might have it, siblings have it, so you can have a think of alopecia areata. So that's sometimes you have to differentiate between, especially if you go to a barber, you can and you find this some barbers some depending on okay, how your haircut done, okay, some people tinea capitis is a fungal infection which can present sometimes hair loss also, but you can see the you can still see hair on the tinea capitis, which is a hair fungal infection, we call ringworm in layman term, okay. You can feel some hair, but in alopecia your skin's very smooth, you can't feel it unless you may see one or two hairs standing out. And sometimes in the kids can be difficult because some people with anxiety problem, they pull the hair. So in that case, you may have a plan similar, but in that case, you can ask in that case, you have multiple small patches there. So it can be different variation in the presentation of this one. You can may just lost the hair, eyebrows only. Okay, in that case, some patients eyebrows only. Okay, one side, both sides can happen, but no hair loss other part of the body.
Okay, so quite a few things you told me here. So I have seen people who will bite their nails, but there are people who can sort of pull their hair from one particular area of the body because of stress, anxiety, or mental health.
Mostly scalp, okay, because of the anxiety symptoms. So these patients they need to, especially we've seen a lot of children have this anxiety symptom. They pull the hair. These patients, these kids, they need to see psychologists for the CBD treatment so that it helps with the anxiety symptoms. They don't pull the hair.
Oh, so that is very important to ask in the history when you are taking the history. Maybe parents will tell you rather than the person itself or child itself.
Sometimes difficult because they present hair loss unless you examine carefully and you can see multiple patches and they're discrete patches. As for alopecia areata, normally you have a very smooth skin. In anticomelia, you have just a small small couple of hairs there everywhere.
And you mentioned barbers. What is the role of barbers
I
in
think
it?
because it's just because sometimes, okay, depending on where some barbers cleaning other things, okay, you can see they clean the combs, okay. Some you can have some barbers they don't clean combs, so make sure, okay, when you go there, you can have a they have in the comb they have the fungal infection, but you go into the skin and can cause hair loss, especially kids.
I see.
Okay,
Okay.
no, it does. You don't see tinea capitis more in the kids. You can see that they can all of a sudden they, and sometimes you can have an inflammation there, and GPs think okay, it could be a bacterial infection, but some underlying problem is a fungal infection. That's why you can hair loss with a little bit of redness, okay, oozing pus from there. Most likely it is a fungal infection. That's why it needs to look into sometimes.
And because it sort of can be transferred from one person to the other,
One
that is
person,
where you come in contact.
yeah.
I see. Okay. So, what would be the, do you think, impact of lockdown when there were no barbers? You think there will be less
Yeah,
people?
maybe I think you can have a, yeah, you're right, because people go to barbers and less hair infection. But really, it can happen, but it's not common, but it can happen.
So the
Okay.
good thing is that one good thing from COVID perhaps could be that now everybody's asking for people to sanitize after every patient. So that perhaps will reduce the transmission of these things.
Yeah, it does, because I think because in the comb this have a, if you someone has a already have fungal infection, you use same comb, and then it can transmit to other people.
Oh,
Especially,
that's very interesting, and I think that's one other good aspects of COVID alongside everything else which is happening. So that's really interesting. So thank you for that. So these are all the stuff which we have talked about alopecia areata. I will come back to you about the treatment. We have got about a minute 30 seconds left before we go on a short break. So I don't want to disturb your thought process around the treatment of this condition. So perhaps we will leave it uh, when we will come back from break. So I just did not mention that in the beginning, that if you guys want to ask any question from Dr. Rafiq, you can ring us on our studio number. It is 01902 972 150. It is only if you're calling from United Kingdom. If you're calling from outside, you perhaps need to dial the country code, which will be 00441902972150. Uh, I think the most important way people communicated with us so far is via WhatsApp text. If you are listening this program on the Ramadan Radio website, you will see a little pop-up underneath which will uh, say send us a text. Use that one. Otherwise, if you're using your phone, the number is 07 440 420 432. You can send us a text or you can send us a voice memo of your question, and we will then ask that question from Dr. Rafiq. Uh, Today's health clinic with Dr. Gillani, we are talking about dermatology and important subject of hair loss and pigmented skin lesions. Going on a break. Stay with us, and we will be back very shortly. Bismillah ar-Rahman ar-Rahim. Welcome back, all listeners and viewers on Facebook Live. This is Health Clinic with Dr. Gillani on the platform of Ramadan Radio Wolverhampton. We are in conversation with Dr. Shahid Rafiq, who is a GP with special interest in dermatology, and today's topic is hair loss as well as depigmentation of skin. We have covered a bit of hair loss already, and we will be moving on whatever we have discussed so far. If you need to ask Dr. Saab any question, please ring us. Our studio number is 01902 972 or send us a text message via WhatsApp, and our number is 07440 420 432. We'll go straight to Dr. Saab and we will ask the treatment of alopecia areata. We have discussed about it, what symptoms, etc. And so it's the time for us to know about the treatment.
And research show that if you have more than if 80% patients have a remission hair growth within 1 year, the hair growth come back within 1 year if you have no treatment. It normally takes 3 months to hair to come back. So if you have someone patient come to you, okay, or I have a hair loss, so you can tell the patient it take about 3 months before they can see a hair growth come back. So if you don't do anything after 80%, but 20% no, I have no hair growth. And also if you have a more than half a hair growth, okay, in the scalp, okay, the part of the body, then I think treatment 1 in 10% chances of hair back completely. So there's no cure for it, but I think we can treat in different ways. We can prescribe some treatment with the steroids cream or steroids lotion, which can be used for twice a day for 1 month, 2 months, have a break, use again, and cycle of it. And some patients respond very well, okay, some patients don't. In that case, we inject steroids into the skin, mostly into the scalp area, and every 6 weeks, and we have found very good results with it. Some patients still partial response. In that case, there where we have problems, okay, how you deal with them. A lot of treatments are available, but there's not definite. We have a few things where dystro cream, which is used in the psoriasis, how does it work? Make the skin very irritated, and the hair growth wake up and hair come back. And there's also contact immunotherapy, which is done locally in Birmingham, and they put a chemical in the skin, and also afterwards put again chemical again. The skin becomes sensitized. In the process of sensitization, you can hair growth. Some places they are using immunosuppressant, which can be used for especially alopecia areata, where whole scalp is gone. So these are things which can be available for alopecia areata. So first, I think once you see a GP, okay, and GP may say, okay, you don't have to do anything, okay, fair enough. But I think after 3 months, nothing happening, I think that needs a referral, or GP can start. If GP is confident, they can start some scalp lotion, maybe once a day for 1 month, steroid scalp lotion, and wait to see until your appointment. We have problem with appointments nowadays, okay. So I think in that case, some GPs can give a prescription for 2 weeks, a month cap, 2 weeks a cycle. At least by the time you go to hospital, they can give injections. Some GPs are able to give some injections into the skin of the scalp, or some in the beard area, which does help in the regrowth of hair.
Okay, brilliant. So these are few medical treatments available to treat it. Again, socially, they can use the camouflage, and
you can use camouflage as here alopecia totalis. You can apply for wig and NHS. Okay, GP needs send a letter to orthotics. Okay, and I think if you diagnose alopecia areata or diagnose alopecia, they can orthotics department at local hospital. They can provide wig to the patients. Some also the departments, they don't take a referral from GP, they refer should be specialist or maybe community dermatology services, hospital services. So they have to go through the process through it. Okay, so but the wigs available on NHS. I think you had to pay, still had to pay whether on prescription, but I think it's available, or you can private wigs available. Okay.
Okay, so if we now move on, and there is some hair loss which happens after pregnancy, and there are quite a few people who will come back and ask they have started losing a lot of hair postpartum. Can you tell us a bit more
This
about that?
telogen effluent, this is a condition which normally, in normal person, you have normally 10% of the hair are shed almost every day. But what happened all of a sudden, all trauma to the body after pregnancy, after childbirth, after you have a major illness, a major surgery, or bereavement, and all of a sudden the body they shed hair. So in that case, more than 30% hair shed. Although you still have hair there, but you've seen the ton of hair loss and general thinning of hair, which take about 6 months to before it come back normally, but it takes 6 months to before you can see the normal growth of hair. So in that case, patient are more reassured. We can arrange some blood tests to make sure any deficiency, or because if you have a major illness or you have a recent baby, you could be anemic. Okay, so with anemia, although there's no direct link with the hair loss, but I think it can help the promote of the growth of the hair. So normally, if you go to GP, have blood test done, okay, all level are normal. But I think for hair loss, evidence say your level should be above 100. Okay, as there's a new evidence coming up on vitamin D can cause hair loss. We're writing a recent paper on this locally on the hair loss and vitamin D, and there's also some elements, zinc deficiency can cause contribute towards. I'm not saying causing; they can contribute towards the hair loss. So this hair loss normally we can reassure patient they come back normal. You don't have to do extensive investigation unless you have information or scarring there. In that case, we have to think about other diagnoses, which such like seborrheic dermatitis.
Right. So I think the Department of Health is saying that everybody who lives in UK is going to be vitamin D deficient unless proven otherwise, and then just take some maintenance treatment over the counter. Is that still true for the same
I
hair
think
loss thing?
I think so. I think you need to keep adequate level of vitamin D in the body, so that I think it indirectly stop the hair loss. Okay, but I think there's no but there's a lot of research going on now behind the scene there with the vitamin D is linked with the hair loss.
Right. Okay. So that's fine. So overall, what is the message to these women? Wait and see, or start on vitamin D and
I think just mostly reassured, okay. But I think if you have some blood tests and make sure you don't have deficiency of iron or vitamin D, that will help you to some better early promotion growth of the hair.
okay, good. Now I perhaps will just want to touch on the hair loss which can potentially happen with what we call dandruff. There are people who got psoriatic patches in the scalp. We have seen the worried parents who come with cradle cap. So these are like little subjects. If you can very quickly tell us about each one of them.
Sometimes, okay, if you look at the seborrheic dermatitis or you have eczema in the scalp and psoriasis, they are difficult to differentiate between them because they're similar pictures. Only thing with psoriasis, you can ask the patient they have they suffer from psoriasis or families of psoriasis, so there's a family history there, and then have rash elbows, knees. So you can say, okay, oh, this person there could be psoriasis, or they have some large confined patch of dry rash or erythema, which can be presented a similar presentation as seborrheic dermatitis, which is a but in seborrheic dermatitis you have similar pictures. You have rash on the eyebrows, also on the side of the nose. So this kind of eczema can be treated with some cold salt shampoo. You can buy over the counter like a tea gel, and capsule. So any cold dry shampoo can be used. Sometimes you have a Nizrol shampoo or Ketoconazole shampoo called Dental. These can be used for maybe twice weekly, not more than twice weekly. Sometimes if you use more than twice weekly, it can cause more irritation skin. Problems come when you have thick scales there. So what you do in that case? Some people use ointments, coconut oil, okay, which take the scales off. So that can be used for this, and also sometimes steroid lotion can be used, which help in the bring inflammation down. But you can't use it all the time. You have to use, normally I suggest to use once a day for 1 month and twice weekly for about a couple of months. So it maintains those. Going back to the cradle cap, which is very common, we discussed in last program about the cradle cap, which where kids have a thick scalp and parents are struggling with it. In that case, again, you have different kind of cold touch shampoo. Again, twice weekly is better, and use ointment, okay, which does help in the take the scales off, okay. And sometimes, in fact, you can use antibacterial creams to put on for 1 week or twice, or 1 week twice a day. That's help in the cradle cap. Eventually, these patients children have a history of eczema in the family, and that's a ratio parents. It will get better, and the hair will come back to normal. Because first couple of months you may find that they have less hair, but over a period of time, and they will hair will come back to in these kids.
Okay, so no need for parents to get worried about it. As the cradle cap will get better, the hair would not get affected. So that's a good news. Now I'm going to throw at you a couple of non-medical layman questions which you do not necessarily need to answer or know about. Any evidence of or any role of aloe vera product for hair?
Aloe vera is used as an anti-inflammatory. Okay, so you may have seen acne. They have a it does okay if you have sometimes have eczema, okay, or you have inflammation in the scalp. Aloe vera does help because it's anti-inflammatory. It has anti-inflammatory factor. So I think you can use, but I think again it's not scientifically proven that aloe vera does help. I think just because aloe vera has anti-inflammatory, it may help. Okay.
Okay, that's fine. And you mentioned about coconut oil, and there are so many other claims around other oils, uh, almond oil or castor oil. There is some Caribbean oil. So, any message, anything which you think is relevant?
We have, I think, because I'm talking scientifically, we have this some creams and some ointment available which has coconut oil, which help in the, and also we have some shampoos of medically, which that's why it's given. I'm not sure about the others. I know you asked someone asked me a question last week, last program also. I want to know where this. I found later on what kind of this oil was. It's
Yeah,
very
no, it is just because they are so commonly used. They are all over the place. So I don't necessarily uh, was expecting that you would know about all of them. But I just wanted to know overall, there is a lot of selling going on about these things, but there is perhaps very little scientific evidence
yeah,
around
but
it.
these all may help in the sometimes may help in the bring the inflammation down. Okay, but other hand, it doesn't affect the hair loss in a bigger way.
Okay, so obviously, if it is hereditary hair loss or if it is alopecia areata, where there is no inflammation, there would be little role of these
Yeah,
things.
if you have the information there, then they might help in that case.
Okay, excellent. Thank you very much. That was extremely useful information around hair loss, and we are grateful for your time. Uh, I think our second topic today is about the pigmentation of the skin and pigmented skin lesion, and extremely common, very worrying, and again, lots of psychosocial problems associated with this particular problem, which we are going to do next, and it is called vitiligo. So, I perhaps will just give you uh, an open ended question. Tell us about vitiligo, what it is, what causes it, and take us through this.
It is a localized depigmentation of the which can be present or persistent, okay, on the body parts. So maybe 1% of population is affected by this vitiligo, and most of patients you may see that start from the early age. Maybe most half of patients start age of 20. You may say children, especially Asian community. They have a lot of kids. Like they have this depigmentation on the face, and also equal, but it's more common in females also. And it may come slowly, may come back again. Sometimes you have a couple of years, then come back again in a year time again. So what normally happen in this one? Okay, you have a melanin pigment, melanocyte, which is cells which has in the skin which produce pigment. They go inactive. Okay, so again, it's because we have, as discussed in alopecia areata, this is also autoimmune, which means the body is fighting against these cells. Okay, and it has evidence that it is related to thyroid problems. Okay, so definitely we ask as a dermatologist if patients have presented to us with a vitiligo, and we in the guidelines of BAD, British Association of Dermatologists, the patient will have blood tests of thyroid antibodies. Okay, because sometimes you might have a normal thyroid function test, but thyroid antibodies, maybe that's why they're asking just to have thyroid antibodies done.
So it is like many other autoimmune conditions, which is when the body's own immune system start working against it and causes various kind of medical problems. You get Graves' disease, which is in the same cohort of autoimmune disease. Similarly, Addison's disease and vitiligo is also an autoimmune disease. And there is some sort of link of if you have one autoimmune disease, there is a likelihood you might get another autoimmune disease.
Yeah, that's why I think sometimes if you think someone has pigmentation problems, we come to the later on whether how you sometimes difficult whether it's because it's a pigmentation problem or whether it's the eczema problem. So we can discuss in a few minutes time. So it's also hereditary. 30% people have problems with the have the hereditary problems with vitiligo in the family. So run the family a lot. If maybe one family have it, but you say they may have pernicious in the family, but they have diabetes in the family, so they'll be linked together. So if you think someone has presented with pigmentation problems, think about the family history, think about okay, who has it. Maybe father might be diabetic, maybe grandparents might be diabetic or thyroid problems. So normally it affects normally symmetrical means it can be both sides. Okay, and it's just both hands. Okay, or maybe both axilla. So normally affect the face openings around the eyes, around the face, on the nostrils, down below. Okay, and also they think it because rubbing of the way rub the skin, for example, in the groin area and in the breast in the woman, also in the also in the armpits. Okay, so these are areas where very common. You may not sometimes they present very small subtle signs of pigmentation problems in both areas. Some areas can be localized, sometimes can be just on one part on the body, which can be difficult, which is difficult to sometimes diagnose or differentiate. In that case, sometimes we have to take a biopsy from it, make sure if you have scattered patches, it may be vitiligo at least stage, but sometimes it presents on the just on the both sides of the body, okay, and easy to diagnose. Especially in the children, sometimes difficult because sometimes you have a another condition kind of eczema, which on the potassium alba on the face, which is a condition which normally happen Asian kids or from they have a something pigmentation, white pigmentation, but along with this, some you can see some dryness on the skin there. So maybe, and you may find this is more worse in the summer season. So potassium alba, which is very common. We have alba. We have a just pigmentation problem only winter, only on summer season only. It's a go away in winter time. So treatment just use motion cream. Sometimes use antifungal. They think maybe antifungal causing it, and it go away. If it doesn't go away, then you have to think about vitiligo. But vitiligo, as I said to you earlier on, normally around the eyelids, nostrils, mouth, also and also hands. You may see the hands and feet also very common, and which is very difficult to treat.
So, okay, so few questions from your explanation. Number one is that vitiligo is obviously when the melanin pigment, which gives the dark color to the skin, fades off. Does it affect equally to Caucasian skin?
It does. Okay, it does. Caucasian skin also. Okay, but I think, it's also but both.
Okay, but it is more sort of pronounced in the people with dark skin, obviously, because it becomes very obvious.
Yeah, so difficult to diagnose sometimes in Caucasian skin because they have a little bit there. But I think it's more obvious in Asian skin. You can see, okay, this is and symmetrical with both sides. Family history, you can always
Okay.
have it.
And you also mentioned that if there is a constant rubbing of the skin surface, that could cause vitiligo. Is that
They think because something happened, the external factors. Okay, if you have rubbed the skin a little bit, okay, and carboniform, with all of a sudden the skin become inflamed. In process of inflammation afterwards, you can have this vertigo can get worse sometimes.
right? And if this happens because of the repeated rubbing of the skin, is that more localized problem as compared to generalized?
It can be anyway, okay, but it can be anyway. Also, sometimes stress can cause it. Okay, sometimes although there are no symptoms in vitiligo, okay, but sometimes stress can cause it. Sometimes you may find sun damage over the years can cause it. Okay, there's a few things which can cause sun damage over the years. Okay, and sometimes some people have problems with chemicals. So what happened? The chemicals uh, make the pigment cells to go pigment go away. So it can happen. So
Okay. So if it happens on a localized skin area, does that mean it always have to spread, or it can just stay there?
it can stay there. In that case, permanent there. In that case, I think some diagnosis dilemma there. You do biopsy because of vitiligo, or maybe fungal infection can sometimes especially on the white skin. Okay, you have this fungal infection, pityriasis versicolor, which is a fungal, especially also comes in Asian skin. Also, but Asian skins become more dark patches, but sometimes difficult to differentiate. So you can have this fungal infection become a white patches. You don't know whether it's fungal infection. In that case, we need a biopsy. We numb the skin with the injection, take a piece of skin to find out, send to lab, find out whether they still have a pigment cells there or not.
So you said it is more common or it first appears more often in younger age groups. Can it happen anytime in the life?
It can have any time. Okay, most of patients, half of patients present below age of 20.
Okay. So the other thing which I wanted to ask is that you mentioned a couple of pityriasis. One is pityriasis alba, which we can confuse with vitiligo. Uh, happens quite commonly or perhaps more pronounced in the dark skin people again.
It is more dark skin. You can see the white patches on the cheeks only, and you may find this more in summer season. Okay, summer seasons go away.
And is that particularly, you said quite common in Asian children, is that particularly in Asian children or it can happen to anybody?
It can anybody. But I think it's more pronounced in Asian skin. Okay, we all have a pigment skin. On top of it, you have a white patches coming on it. Okay, and that's why you need to sometimes differentiate between both of them.
And what happens with pityriasis alba? Is that a better news than vitiligo?
Yeah, it's better. Let's go away, and okay. And once you treat after I think child grow up, they get better with time. Again, it go away. With vitiligo, then it's come back, and it's difficult to treat sometimes.
Okay, and is that anything to do with fungal or is that just one of those things which we don't know?
There's a theory behind it. They think it's because of fungal infection, okay, or fungal element on it, or sometimes you may find this more pronounced in sun also. So they think when sun goes on the skin, the fungal city underneath the skin may grow up and can cause pigmentation in the skin. So that's why sometimes it's treated with antifungal creams initially and a moisturizer cream all the time.
Okay. Right. So vitiligo obviously is, I have seen it is a very, very distressing condition, especially as you said, it comes on the face and they are patches which are depigmented, quite pronounced. And I think most of us would get distressed if there is this kind of problem. You mentioned skin biopsy can be done. Some other tests like thyroid needs to be done. The bottom line is, can it be stopped, contained, or treated?
There's no cure for it. Sorry. Okay, but it can be treated. The take-home message is, if you have a vitiligo, the first is that you have to use sunblock all the time, because when you have because pigment melanates protect the skin, then you can burn easily. And second thing is camouflage. these are more treatment options available. We have to camouflage the skin, if especially as you say, psychosocial aspect of it, okay, and also sun damage. So with the camouflage, there's a organism called changing face. You can Google it. Okay, go on it. You can self-refer yourself. I think you self-refer. There's a long waiting time. If you go to GP can do it. Okay, there's a laborious process. You have to go online and do it. Okay.
So this is a website you're mentioning.
Yes, Youth with Charity or Red Cross used to have it. Now it's a website, it's a charity changing face. What they suggest powder and also the cream for you. Then you can go to GP. They can prescribe it. You can go to privately. You can go to any drugstore. They have this special pigmented creams going to skin. They can match. They give it. Okay. But I think NHS, if you have the long waiting time for it, the local centers of Wolverhampton, Shrewsbury, and Birmingham. So once you see them, okay, then they suggest this treatment. You can go to GP. They can prescribe on the prescription. Otherwise, it costs you more if you go privately to buy this camouflage creams.
So tell us a little bit of what is camouflage. You mentioned it as a option for few things. So just for my listeners, tell us what it actually means. And
it does work. What they do, they have different colors of the skin. Okay, from brown to black. So the different skin, okay, they match with your normal skin. So that when you put this camouflage powder and cream,
so it's like a makeup.
It's like a makeup, but it's slightly more. Normal makeup may not cover your what's like on the face or other areas. It's like a makeup, heavy makeup, and it does help you, okay, especially on the face, other places, to hide away your pigmented areas.
Right. So and you said that you can get it via this particular charity called Changing Face.
Changing Face.
And you can go online and you can self-refer yourself. There is going to be a waiting list.
I think there's a waiting list. You can self-refer, or you can go to the GPs. Okay, they can refer through the Changing Face. Okay, were you seeing a specialist over there? Then I think you can refer from there. Easy to from there specialist refer, because they pick it from there. They have diagnosis. Because sometimes if you self-refer, they're not sure you have diagnosis, right diagnosis or not. Sometimes it's better to have professionals, and these patients are pushed back. So if you have to go to professionals, they're like GPs, or you go to the community dermatology services or GP special interest, or then these patients, and they send an email or they send a text message to the patients and then send appointments and link with it.
Right. Okay. Anything else other than camouflage?
Okay, so sun protection, okay, and also then you have a treatments available in the form of topical creams, okay, steroid cream, okay, we can use it for a couple of times a day. Normally you have for 2 weeks, a month gap, 2 weeks, okay, and sometimes you have some patients has started with the sudden vitiligo body, so we can oral steroids also can be given on a reducing dose for 1 month, 6 weeks, but it has side effects with it. So people avoid to use oral steroids, they start to use topicals. Nowadays we have treatment available with the portable immunomodulators, the creams like immunomodulators. We can use Eladel, Protopic. These are two available in the market, which can be used along with steroids. Okay, so you normally 10 days, 2 weeks, so there's a different regime for it, which can be especially in the children, because you can't use. Parents are worried because they can't use steroids long term because of the skin thinning side effects of them. They can be used for longer term. This immunomodulators. So in children, preference is instead of steroid, we give the immunomodulators, which is another kind of treatment available in the cream form. Moving forward from there, then we go to surgical treatments, and you have a before the surgical, there's a phototherapy treatment, which is very very successful. So once patients don't respond to this treatment, then go for phototherapy treatment. Or patient come to you have a extensive kind of vitiligo, we would say to the phototherapy treatment, UVB, which is a controlled phototherapy, not a sunbeds outside. Some patient may find in summer season the vitiligo will get better, It doesn't mean you expose to sun because you have more chance of sunburn because of it. So phototherapy is normally 6 weeks, um, um, twice a week, up to 3 times a week, 6 week sessions, and we have very good results locally, and with good results come with the phototherapy treatment. And then later on laser treatment coming up, and some people have depigmentation surgical treatments which is not available in NHS. So these are NHS can provide this um, phototherapy treatment and creams.
Okay, thank you for that. And you mentioned few time sun protection. Can you sort of give us a bit of overview of what should parents or people should be looking for when we particularly say sun protection, and how does it work?
Sun protection, I think when you buy the cream, normally I think just you're looking for what like you need SPF 50. You look at the what's rating the SPF. Okay, 50 is 30 above 30, but go for just like we discussed melasma in the next talk. Okay, the SPF 50. So at least SPF 30. Then and also look at the stars. Okay, you can see the star rating on it. Higher the star is, the better it is.
So the SPF is a sun protection factor, if I'm right,
Yeah.
and it is labeled on quite a few of
Yeah, you may
the.
find some people have makeup on. Oh, I use it with makeup on. Sometimes makeup may not work, especially melasma and vitiligo. You need something proper sun protection creams, and you can put makeup on top of it. So best to have a better sun protection creams. And also, you look at the star rating on them. Okay, on the back of the star rating, look at the star rating on it. And also, if you go on holidays, you have to use a couple of times every couple of hours. And try to avoid the sun between 11 and 3 o'clock also if you're going on holiday. So if you already have a vitiligo, you already have some pigmentation problems. So avoid the sun this time and avoid a couple of times. And also, there are some nowadays available, which is you can use when you go to holidays. You can use along with the in the pool.
So they are waterproof
Yeah,
sun protection.
there are some along with the makeup also. There are some special with the face also. So a lot of varieties available. You have to shop around in the supermarket or online.
And once you have applied the sun protection lotion or cream or spray, whatever it is, how long it stays, and what is sort of the advice?
Depending on what circumstances outside is whether it's sweaty, it come off. Okay, so you advise to use every couple of hours. If you go out in the sun a lot, like if you do just off job, you can just work to them. Maybe once a day should be okay. Um, uh, Other thing with sun protections. What was in my mind? Sorry, I forgot.
No worries, it will come back. So most people go out on holidays and want to get suntan. Does these sun protection help in stopping suntan, or they can still get suntan despite that they are wearing the sun protection?
If they wear suntan, they can burn them depending on the type of skin they are. Okay, and if skin what type of skin it is, okay, then they can burn the skin even if they use sun protection. Okay, so
So
it's not.
despite the sun protection is on, they can
Yeah,
still burn it.
they can still burn it, and if it's burning it, then maybe some skin condition can be. It means they are allergic to sun. Also, they need to think about other skin condition.
So it's moderation, and I think 11 to 3 is the highest UV time for
Yeah,
the sun.
yeah.
And okay, that's brilliant.
Message not to have exposed to sun a lot. That's maybe being dermatologist, because I see a lot of young persons coming to me nowadays in 20s coming a basal calcium on the face, other part of the body now. Maybe 10 years ago, I see only a lot of patients for late 30s, late 50s or 60s, 70s. Now, we have a lot of patients, young people coming from the melanomas and also skin cancers now. So avoid this sun exposure. Also, these sunbeds.
Okay, great. Okay, so message is avoid uh, excessive sun exposure if you can, because it can save you from lots of skin problems. Related to vitiligo, there is a condition called albinism. Is that something to do with vitiligo? Is that something very different?
That's something different. Like albinism. In that case, you have the congenital problem there, and also it has a genetic disorder. So I think that's in that case they picked an early stage and they have blood tests done. They have other organ involved in this one. So that's more genetic disorder. In that case, I think You may have only no part. We have all bodies involved in that case.
So all body can get depigmented, but it
Yeah.
is not vitiligo, and it has different condition, runs in the family, picked up early, and basically is not a good news.
Yeah, it's not good news. That.
Okay, excellent. Now we have about 5 minutes before we go on our azan break, and we will then have 10 minutes after the azan break. So I'm just sort of going to start the next topic, and we will just cover what it is before we go on azan break. And it is a condition which is again common, especially women in their 40s. They come, and quite often it affects the face. Lots of psychosocial issues around it, and that is a skin condition called melasma. So can you please tell us what it is?
Melasma is the increased pigmentation on the face, and because there's some factors which can make the size of the pigment melanocytes big in the on the face, and that's cause increased pigment, especially in the forehead, face, nose, upper lip area. And it's very common in a female, although can be men, but men only 10%, but mostly it is females. Very common 20 to 40-year age, and a lot of and also it also have genetic link. If 30% people have it, okay, in the family, so they have a mom has it, daughter might have it, okay. It's more hormonal on during pregnancy, especially in the last 3 months pregnancy, get more worse, and also patients on the pill and contraceptive pill, they can cause it, okay. So it's, and also sun exposure. If you expose the sun a lot, and then your melasma get worse. So there's a damage to cells which can cause, okay, and which can also, these are few factors, external factors which can cause a melasma, especially on the face.
So is that looks like more dark patches on the
Yeah,
face?
you may find a scattered dark patch especially in the cheeks, only upper lip area, and the forehead area, and normally they happen out. Normally it's normal for pregnancy, but as time goes on after pregnancy, they carry on, and also some young people have it. And then also this is very common we come across, and as I say, it can cause local psychosocial dilemma for ladies, especially, and what treatment options are available. Is again, it's, you have to think about what's causing it, and how you prevent it, make it more worse, instead of using a lot of other things over the counter. People using it.
Okay, so we will definitely come back to that. We will be soon going on azan break. So I just want to do a quick uh, summary of what we have dealt with so far. We talked about hair loss. I won't repeat that. We have talked about vitiligo, a very important condition. It's the depigmented skin patches, which most often noticed on the hands and face of people. And Dr. Veek told us it is usually symmetrical, which means it is presented on both sides of the body. Uh, it is autoimmune condition. The treatment is basically you can't do much except you try to deal with those patches either with camouflage, which is a specialist type of makeup, or you go for a controlled phototherapy under the care of dermatology, or you can consider some options like lasers, but they are not available on NHS, and then you perhaps have to pursue it privately wherever you like to go. Uh, we are going on azan break. After the azan break, we will have another 10 minutes when we will talk about further about melasma, and if we get some time, we might need to take any other relevant questions to the topics today. If you have got any question, you can contact us via WhatsApp. If you are listening us on the website, you can just press the button contact the studio, and it will send us a WhatsApp text from your mobile phone. If you want to ring us and ask us a question or ask Dr. Rafiq a question, you can ring us on our telephone line to the studio, which is 01902 972 150. Our WhatsApp text number is 07 440 420 432. Today's health clinic is about skin conditions, where we have talked about pigmented skin lesions, and we will come back after Azan break, and very short next part of the program will be around treatment of melasma. So stay with us. Welcome back, listeners and viewers. This is Health Clinic with Dr. Rizwan Gillani from platform of Ramadan Radio, Wolverhampton. We are doing today's health clinic on skin conditions, which included hair loss and pigmented skin lesions. We have now so far covered a lot of uh, subject around hair loss as well as vitiligo, and we were in conversation with Dr. Rafiq. He is a specialist interest GP in dermatology in Wolverhampton with a very extensive experience of doing specialist dermatology for over 10 years. And he was very kind that he has given us that much time today to discuss these two very important topics which are affecting lots of people. So we talked about what was melasma, which is basically the darker skin patches on the face, common in females, related with pregnancy as well, but it can be hereditary, which means it can run in families as well. So, Dr. Rafiq, coming back to melasma, can you tell us whether it is just a clinical diagnosis or there is some other workup is needed for diagnosis?
Sometimes, especially in Asian patients, difficult to diagnose because they have already have eczema over there, and then they can cause post-inflammatory hyperpigmentation. Okay, but history will tell you young person coming to you have recent pregnancy or they're on the pill. So in that case, we can take biopsy to confirm the melasma. But I think most of the more clinical diagnosis, and you can try ask to change the pill to low estrogen level pill. Sometimes high estrogen is it can cause more of a pigmentation problem. So you can ask the GP to change the pill to low estrogen level. And but sometimes you have to do biopsy, mostly skin diagnosis, uh, because pigmentation. So sometimes it's quite darker. Sometimes difficult to differentiate it because of pigmentation problems. Because they might have eczema, might have a reaction to sun before. Then these are post hyperpigmentation, which is difficult to treat also, and the cream treatment we use doesn't work on it. The take-home messages from the sunblock. Melasma is sunblock. If you want to make it less worse, sunblock all the time. In these patients, we need sunblock almost every day, especially in summer season. Even in winter, when they go out, they have sunblock, and that will help you not to make the melasma more worse. Then treatments difficult. There's no cure for it, but sometimes treatments are very difficult to treat it. You can try to change the pill, and afterwards, what's left is the treatments available is hydroquinone, which is available over the counter, available in the hospital setting where over the counter is available in different forms nowadays. You can buy over the counter, okay, which is a similar hydroquinone creams which help in the pigmentations. The first line therapy, you can in hospital settings and other settings, what you use a hydroquinone also along with some retinoids cream along with steroids, because retinoids take the peeling skin, and quinones does help in the hydroquinone that help in pigmentation, and because these cause inflammation, and you use steroids and this combination 3 creams which does help in the one is to take the inflammation away, other way to take the pigmentation away. If you use isolation with the hydroquinone, which can cause inflammation, sometimes more irritation skin, that's why I try to avoid them separately. If you have combination of them, you can get from the prescriptions. As a GP level, they can some cream which is retinoid creams and which can be used for acne, also can be used for melasma. Normally 6 weeks course, most of them okay, try 6 weeks. Okay, also other one we use it the bleaching creams which are available from the hospital setting. They have specials, and they have to make a special. It costs a lot of money now. There's trend towards to less prescribing, because it does cost £50 to £200 per cream. So 6 weeks course. So eventually there's less prescribing of this one happening, because if you go to chemist order, it takes cost more. If you hospitals that have a bulk buying, it does help in cost saving. Then there's a new evidence coming up, which is unlicensed tranexamic acid. We use tranexamic acid nowadays for the for periods pain, okay, but and other clotting problems. But it has been used in some Australia and USA. They use for melasma, which have been used, but you have to tell the patients on license. But I think it's coming up another oral treatment therapy, which is only one available for this one. Moving on to non-NHS treatment, okay, you have chemical peel available, blue peel available, and they have mixed. Results. Some people have very good results. Some people have a more pigmented problem afterwards. So it really depends on whom you go, where you go, what they're using it. So the chemical peels are useful, are they helpful? But I think again, where you go, who's doing it, what type of skin you're having it. Okay, you already have a lot of skin, darker skin, you have more pigmentation afterwards. Some people have good, very good results. The bottom line is the sun protection to make it protect more skin and less worse. But these are treatment options available on NHS.
So you mentioned about non-NHS treatment of chemical peel, and that sounds to me that they use certain chemicals on that area and then they will try to sort of peel off the top layer of the skin. Is
Yeah.
that correct understanding?
Yeah, normally I think if you go one off the peel doesn't happen. What normally proper peel, they prepare the skin first. They use retinol cream a couple of months, a couple of weeks, and before start of this treatment, then do peel. Yes, take the top skin of layer. That's how does it work.
So, just for the people out there who are listening, and if they want to go for that non-NHS choice, what type of research they should do? If you recommend any research they should do to go, because you said the outcome varies with different providers or different people who are offering that. So, what should they be looking for? Is there any sort of guide for them?
I think they should go professionals. Okay, just like people who qualify to do it. Okay, and who can do a more better peel. Sometimes they use very low. You pay so much money, then you then found that they use a very low retinoids in it. It doesn't work. You go back again. So and also look at reputable companies. Okay, who are doing it. Okay, and who's doing it. That's very important. Okay, and whether any effects of it, and also make sure they assess you properly. Some people, when they personally assess you, okay, it's not suitable for you. Okay, we can't do it. So need to research yourself. Market is open now everywhere. Everyone out in the corner, everyone doing this piece, but you have to be careful because it can make it more worse. It can cause problem scarring and problem pigmentation problems. So you have to be careful before you go to any chemical peels or retinoid peels.
Okay, so it is all down to the reviews they need to look for, or there are some qualifications they need to look for?
I think the more for qualifications and reviews can be variable. Some reviews can be hit or miss. Okay, so look for the qualifications. Who's doing it? Okay, and they have any qualification with this aesthetic use. Okay, so just have to look for this, and it's quite market is open and quite variability there. So it's difficult to comment on this one. Whom to go? But I think they have to patient have to know their own research on it.
Okay, excellent. Thank you very much. So we are coming to the close of our program. I just want to say thank you very much to Dr. Rafiq that he has kindly given us that much time to share his expertise and knowledge with us. I'm sure my listeners and viewers would have got some benefit out of it. We are extremely grateful, Dr.
Thank you, Rizwan, once again inviting me today.
And hopefully we will have pleasure of your company at some other time with some more topics available to us. If my listeners or viewers want to discuss anything in particular, just text us anytime so that we welcome your suggestions and we try to tailor our program accordingly. Today's program was around skin conditions like hair loss and pigmented skin lesion, where we talked about vitiligo and melasma. And I hope you would have found some useful information in that. I think if one take home message anybody wants to remember, protect your skin against sun as much as you possibly can. Next week is going to be Eid ul Adha, so it won't be our program, and I will come the week after with a new topic. Until that time, Eid Mubarak prior to the Eid day, and look after yourself and your family. Take care. Assalamu alaikum.